So picture this. You walk into a hospital room, or, maybe you're just watching a medical drama on TV, and there it is.
Oh, yeah.
Right. The clear plastic bag hanging on that metal pole, just sort of slowly dripping liquid into a tube that disappears into someone's arm. It's like practically the universal symbol of modern medicine.
It really is.
And you look at it and you probably think, hydration. The tank is low, so they're just giving the patient some water.
Yeah, which is, it's the most natural assumption to make, right?
Right.
We all sort of carry this mental model of the human body as like a series of rigid pipes. So if a patient is sick or bleeding, well, the pipes are emptying out.
Exactly.
So you just hook up a bag of water to refill the plumbing. It just feels incredibly straightforward.
It does. But then you actually start digging into the science of those fluid bags, and suddenly that whole simple plumbing analogy just completely falls apart.
Oh, completely.
So welcome to the deep dive. Today, our mission is to unpack the fascinating and honestly highly counterintuitive world of 5V fluids.
Yeah, it's a wild ride.
Because what the sources reveal is that this is so much more complex than just, hydration. We're actually going to explore 3 genuinely surprising realities today for you. First, a fluid bag, clearly labeled isotonic, can actually act as a hypotonic water bomb once it's inside you.
Which is terrifying.
Right. Second, normal saline isn't actually physiologically normal at all. And third, the textbook standard for pediatric IV fluids was quietly harming children for 50 years before the medical community caught on.
Yeah, that one it's a really profound shift in perspective when you realize what is actually happening in that plastic tubing.
So where do we even start?
Well, to understand why those 3 things are true, we need to establish a foundational definition for you. At its core, an IV fluid is a sterile water-based solution infused directly into the bloodstream.
Okay, simple enough.
Right, but the single most important concept here isn't the water itself. It's a property called tonicity.
Tonicity?
Yeah. Tonicity basically describes how that specific fluid forces water to move across human cell membranes.
Okay, I want to spend some time here because, to understand how IV bags work, we really have to visualize this microscopic tug of war. It's happening between the fluid we're pumping into the vein and all the billions of cells lining those veins and making up the surrounding tissues.
Exactly. So there are 3 main classifications of fluids you need to know, and they're all based on this concept of tonicity.
Okay.
And we benchmark this against human blood plasma, which has a very specific, tightly regulated concentration of dissolved particles.
Like salt and stuff.
Yeah, mostly sodium, chloride, glucose, and urea. And that baseline concentration is roughly 275 to 295 milliosmoles per liter.
Okay, so 275 to 295 milliosmoles per liter.
That's the target. So the first type of fluid is isotonic.
Iso meaning same.
Exactly. This fluid has roughly the same effective solute concentration as your blood plasma. When you infuse an isotonic fluid into the bloodstream, the surrounding cells neither gain nor lose water. It creates a state of balance.
Got it.
The second type is hypotonic. This fluid has a lower concentration of solutes than the blood plasma.
Okay, so less stuff, more water.
Right. And because of the laws of physics, water naturally wants to balance things out. So the water actually leaves the bloodstream and forces its way into the more concentrated cells.
Oh, wow.
Yeah, and that causes those cells to physically swell up.
That sounds dangerous.
It can be. And then the third type is hypertonic. This has a higher concentration of particles than plasma.
So super salty or sugary.
Exactly. So in this case, water is violently pulled out of the surrounding cells to dilute the blood, causing those cells to physically shrink.
Okay, so to help you visualize this at home, I was actually thinking about an analogy while I was reading the sources.
Oh, let's hear it.
Okay, so imagine the dissolved solutes, like the salt or the sugar particles. Imagine them as the life of a great party.
Okay, I like this.
And the water. The water is the crowd. And, the crowd always wants to leave the empty, boring room and rush into the room where the party is actually happening.
That's spot on.
So if you inject a hypertonic fluid, you are basically throwing a massive concentrated party right inside the bloodstream.
Right.
So all the water inside the body's tissue says, hey, let's go out there, and rushes out of the cells to join the party, which shrinks the cells.
That paints a very accurate picture of the mechanism. And, for most of the 20th century, doctors basically operated under the assumption that these properties were simply fixed numbers printed on the bag's label.
Like whatever the label says is what you get.
Exactly. If the label said the party was a certain size, well, that was the end of the story.
Yeah.
But modern physiology makes this really sharp distinction that completely changes how we administer fluids.
Okay.
There is a massive functional difference between osmolarity and tonicity.
Okay, I'm going to need a timeout on this one.
Sure.
Because if the bag is manufactured in this highly controlled, sterile factory, how can the label be wrong? I mean, if it says it has a certain number of particles, aren't particles just particles?
Well, that's the trick. Osmolarity is exactly what you just described. It's the total absolute count of dissolved particles in the bag per liter.
Right.
You measure that in a chemistry lab, and the factory label is 100% accurate about that exact number.
Okay.
But tonicity is the effective osmotic pull that actually drives water movement across a living biological cell membrane.
Oh, I see.
Yeah, and those two concepts are not always synonymous because some particles are sneaky.
Sneaky how?
They can just pass right through a cell membrane without any resistance. Urea and ethanol are like classic examples.
Oh, so they don't trap the water.
Exactly, because they cross freely. They don't force water to move at all. They add to the osmolarity number on the factory label, sure. But inside a human being, they have zero tonicity.
Wow. Which actually brings us directly to that first major revelation from the intro, the D5W paradox.
Yes.
I was reading this section and trying to map it out in my head. So D5W is 5% dextrose in water.
That's right. And if you read the bag, its osmolarity sits perfectly in that 275 to 295 range.
So on paper, it's an isotonic fluid.
Exactly. It looks like it should just sit nicely in the blood vessels and maintain balance.
But dextrose is literally just a form of sugar.
Mm-hmm.
And the cells in our body constantly need sugar for energy. So if we pump this supposedly balanced sugar water into a vein, the patient's cells are going to rapidly consume all that dextrose.
Right.
They basically eat the party.
They devour the salutes entirely. And once the body metabolizes all that dextrose, what is left circulating in the patient's veins?
Just plain water.
Plain free water. So a fluid bag that was clearly labeled and manufactured as isotonic actually behaves as a hypotonic solution once it interacts with human metabolism.
That is wild.
It drops the concentration in the blood and sends all that free water rushing into the patient's cells.
Which, okay, knowing that we can manipulate water like this, forcing it in or out of cells by changing the guest list to this cellular party, it raises a major clinical question for me.
What's that?
Why would a clinician ever want to intentionally force a patient's cells to swell or shrink? I mean, shouldn't the goal always be to maintain that perfect isotonic balance?
Well, maintaining balance is absolutely the goal for basic resuscitation.
Right.
Like if someone is rushed to the ER with severe blood loss from a car accident or massive fluid loss from a gastrointestinal infection, their blood pressure is plummeting.
So you just need to refill the pipes.
Exactly.
Yeah.
You need to refill the pipes just to keep the heart pumping and oxygen flowing. Clinicians use isotonic fluids here because they want that fluid to stay inside the blood vessels. You definitely do not want it shifting into the surrounding tissues and causing complications.
But the sources discuss the use of hypertonic fluids, and I had a really hard time wrapping my head around this.
Yeah, it sounds backward.
Right. Under what circumstances would you ever want to intentionally dehydrate and shrink a patient's cells?
The primary application is for cerebral edema, which is severe swelling of the brain.
Oh, wow.
Because the brain is a really unique organ. It's completely encased in a rigid, unforgiving bone box. The skull.
Right. There's no room.
None. If brain cells begin to swell due to a traumatic injury or a stroke or a tumor, they have nowhere to expand.
Yeah.
So the physical pressure inside the skull starts building rapidly.
And if that pressure gets too high, it eventually just crushes the brainstem, right? Which controls breathing and heart rate. It's basically fatal.
It is. So to prevent that, a critical care team will push a highly concentrated hypertonic solution, usually like a very strong saline, into the bloodstream.
Ah.
So following your analogy, they throw an aggressive party inside the blood vessels of the brain.
And the water leaves the brain cells.
Exactly. The water that is dangerously trapped inside the swollen brain tissue is drawn across the blood-brain barrier and into the bloodstream to dilute that massive salt load.
That is incredible.
It physically shrinks the brain cells, a cellular process known as crenation, and it relieves that deadly mechanical pressure inside the skull.
The physics of water being used to literally decompress a brain, that is just wild to think about.
It's elegant, honestly.
So, okay, on the flip side, when do we use hypotonic fluids? Like, when do we intentionally swell cells?
Hypertonic fluids come into play when a patient is suffering from profound intracellular dehydration.
Okay.
A prime clinical example of this is diabetic ketoacidosis, or DKA.
Okay, I've heard of that.
Yeah, in severe DKA, the patient's blood becomes so thick with unmetabolized glucose that the blood itself acts like a hypertonic fluid,
Oh. So the blood is sucking the water out of the body.
violently sucking water out of the patient's own tissues. Their cells are effectively shriveling up.
Wow.
So once the medical team stabilizes the patient's blood sugar and initial volume, they will often introduce a hypotonic fluid to gently push free water back into those parched cells to rehydrate them.
But there has to be a dark side to this, right?
What do you mean?
Well, if you are pushing water into a cell with a hypotonic fluid, isn't there a point where the cell just, I don't know, just can't take it anymore, like overfilling a water balloon?
Oh, absolutely. It is a critical risk factor.
Yeah.
If you administer too much hypotonic fluid or if you push it too fast, you can trigger RBC hemolysis.
Hemolysis, meaning what exactly?
It means the red blood cells circulating in the veins swell up with so much free water that their structural membranes simply cannot hold the tension. Yeah, they rupture and burst open directly in the bloodstream, which is a catastrophic event.
Wow. This requires like a surgical level of chemical precision.
It really does.
Which naturally makes me wonder about the history here. I mean, how did humanity figure out this exact benchmark? The 275 to 295 milliosmoles thing. Like, how did we learn to manufacture these safely?
The origin story in the sources is fascinating because it wasn't just a single scientific breakthrough.
Right.
It was a collision of two vastly different worlds over several decades. On one end of the spectrum, you had the 19th century physicists and physical chemists.
Okay.
Men like Wilhelm Pfeffer and Jacobus Henricus van Hoff.
Right.
And they operated in these pristine, quiet laboratories, meticulously studying plant cells and deriving the fundamental mathematical equations for osmotic pressure.
Doing the math.
Exactly, mapping out the invisible laws of how water behaves.
But calculating osmotic pressure in a quiet lab is worlds away from, keeping a dying human being alive.
That is exactly where the clinicians enter the picture. And their environment was the exact opposite of pristine.
Yeah, I bet.
In the 1830s, Europe was devastated by horrific cholera pandemics.
The blue terror.
Right, the blue terror.
Yeah.
Cholera causes such violent, relentless diarrhea that patients literally dried out.
Ugh, that's awful.
It is. Their blood would lose so much water, it turned into this dark, thick sludge that the heart could barely even pump.
Wow.
And a Scottish physician named Thomas Latta read theories about injecting water and salts directly into the veins. Driven by just sheer desperation, he began experimenting on dying patients.
So he didn't have all those fancy equations.
He didn't have Van Hoff's equations at all. He was basically just trying to mimic the salty taste of blood.
It was raw trial and error on human physiology.
Entirely. Latta and subsequent pioneers like Sidney Ringer and Alexis Hartmann, they would inject various concoctions of boiled water, salt, and eventually sodium lactate, just to see what combinations kept people alive.
Without causing convulsions or that hemolysis we talked about.
Exactly. So over decades, the rigorous, pristine physics of the laboratory finally merged with the messy, desperate clinical survival data from the cholera wards.
And that gave us the formulas.
Yep, eventually yielding the precise 5E formulas we rely on today.
But here is where the narrative takes a really sobering turn, I think.
Yeah.
Because we often think of modern medicine as this steady, unimpeachable march of progress. But the sources highlight a terrifying complacency that eventually set in.
You did.
The medical establishment got comfortable, and they got some major things wrong. Which brings us to the holiday cigar failure.
Yeah, this is one of the most sobering case studies in modern pediatric medicine, honestly.
It really is.
In 1957, two well-respected doctors, Holliday and Cigar, developed a formula to calculate the daily maintenance IV fluids required for children who couldn't eat or drink.
Okay.
Their formula was mathematically brilliant for calculating the volume of fluid a child needed based on their weight. But the type of fluid they recommended to fulfill that volume was heavily hypotonic.
Right, because they based their fluid composition on the electrolyte profile of healthy breast milk and cow's milk.
Which sounds logical, right?
It sounds totally logical at first glance.
It sounds logical until you realize that healthy milk is processed slowly by the gastrointestinal tract of a healthy infant.
Oh, right.
It is not injected directly into the systemic circulation of a sick, stressed child lying in a hospital bed.
Yeah, that's a huge difference.
When a child is hospitalized with an illness or undergoing surgery, their body naturally panics. It releases a flood of stress hormones, specifically antidiuretic hormone, which screams at the kidneys to stop producing urine and hold on to every drop of water possible.
So the kid's body is already aggressively hoarding water.
Exactly.
And then the medical team pumps bags of hypotonic fluid, which, as we established earlier, leaves behind a massive load of free water directly into their veins.
The result was severe dilution of the blood. The sodium levels in these children would plummet to dangerously low levels.
Wow.
It's a condition called hospital-acquired hyponatremia.
And if the sodium in the blood drops too low, the blood becomes hypotonic compared to the brain cells.
Yes.
So the water rushes into the brain, causing the exact cerebral edema we talked about earlier.
Exactly. And for over 50 years, the undisputed textbook standard for pediatric maintenance fluids was quietly causing neurological damage, seizures, and in several tragic cases, death.
Just from the routine fluids.
Simply from the routine IV fluids ordered upon admission. It wasn't until 2018 that the American Academy of Pediatrics finally, officially reversed this half-century-old standard.
2018, that was practically yesterday.
I know. They issued strict guidelines that isotonic fluids must be the standard for pediatric maintenance.
50 years of standard practice, it is genuinely unsettling.
It is.
And it underscores just how delicate the body's sodium balance really is. Because the sources point out another complication of fluid mismanagement, and I actually had to read this section twice just to process the severity of it.
Oh, osmotic demyelination syndrome.
Yes.
Yeah, if you zoom out and look at the bigger picture of tonicity, osmotic demyelination syndrome is the devastating consequence of trying to fix a complex problem too quickly.
How so?
Well, if a patient comes into the emergency room with severe chronic hyponatremia, meaning their blood sodium has been dangerously low for days and their brain cells have slowly absorbed water and swollen to adapt to this new environment, a clinician might look at the lab results and think, I need to give them highly concentrated hypertonic saline right now to fix this number.
Right. I mean, the tank is low on salt, so just dump the salt back in.
But if you correct that sodium deficit too rapidly, you radically shift the tonicity in the opposite direction.
Oh.
The hypertonic saline violently sucks the water back out of the adapted brain cells. It shrinks the cells so rapidly and aggressively that it physically tears the myelin sheath.
Which is the insulation, right?
Exactly. It's the protective fatty insulation wrapping around the nerve fibers in the brainstem. You are effectively stripping the insulation off the brain's wiring.
That sounds horrific.
It causes irreversible neurological damage, locked-in syndrome, or even death. It is a permanent reminder that in fluid resuscitation, the velocity of the fluid shift is just as dangerous as the shift itself.
Wow. So with all these historical blind spots and microscopic tightropes that clinicians have to walk, you would think we have it all perfectly mapped out now.
You would think.
But I noticed a huge ongoing conflict in the critical care sources. It seems like a modern group of doctors started demanding massive trials to challenge the fluids we use every single day.
Yeah, the science of critical care fluid therapy is far from settled. If you look at the modern landscape, 2 massive clinical trials have completely disrupted the status quo.
The SAFE trial and the SMART trial.
Exactly.
Okay, let's tackle the SAFE trial first because this gets into the debate between crystalloids and colloids.
Right.
Everything we've discussed so far, saline, dextrose, these cheap bags of dissolved salts and sugars, those are crystalloids.
Correct.
But the sources define colloids as fluids containing massive molecules like human albumin, which is like a large protein derived from blood plasma. But from what I understand, the argument for using these expensive proteins all comes down to the Starling equation.
Yes, it does.
I want to try explaining this, actually, because it really changed how I view the cardiovascular system.
Oh, go for it.
Okay, so we tend to think of our blood vessels as solid rubber pipes, but the capillaries are actually semi-permeable.
Right.
So they're more like porous soaker hoses in a garden. Water can easily leak out of them to the surrounding tissue, causing severe swelling.
Exactly.
But according to the Starling equation, the giant proteins naturally floating in our blood act like water magnets.
Yes.
They are physically too large to leak out through the pores of the soaker hose, so they stay inside the blood vessel and hold onto the water with a pulling force called oncotic pressure.
That is a phenomenal way to explain oncotic pressure.
Thanks.
And that was the fundamental theory behind using colloids. Clinicians argued that if a patient is critically ill and their blood vessels are leaking, we shouldn't just pump in cheap salt water that will immediately seep right into the tissues.
That makes sense.
They thought we should pump in expensive colloid proteins to act as massive magnets, pulling the water back into the pipes and keeping it there.
Okay.
So the SAFE trial was this massive international effort designed to finally prove that colloids were superior for saving lives in the ICU.
But the results didn't exactly match the theory, did they?
They did not. The SAFE trial demonstrated that, for the vast majority of critically ill patients, resuscitation with cheap, basic crystalloid salt water resulted in the exact same mortality rates as the expensive albumin colloids.
Wow, really?
Yeah. While there are still very specific niche uses for colloids, like in certain liver failure patients, the trial proved that for everyday critical care, the basic physics of salt and water are sufficient.
Which brings us to the SMART trial and our final mind-bending fact from the beginning of the deep dive.
Ah, yes.
The myth of normal saline.
Yes. So 0.9% sodium chloride is universally referred to as normal saline.
Right, you hear it all the time.
It is the most ubiquitous, heavily utilized IV fluid on the planet. But from a purely physiological standpoint, it is incredibly abnormal.
Wait, really?
Yeah. Human blood plasma has a chloride concentration of roughly 100 milliequivalents per liter. Normal saline contains 154 milliequivalents of chloride per liter.
That is over 50% more chloride than the human body is designed to handle.
Exactly. And when a trauma patient or a sepsis patient requires massive volume resuscitation and you pump liters upon liters of normal saline into their veins, that immense unnatural chloride dump wreaks havoc.
I can imagine.
The heavy chloride load constricts the blood vessels inside the kidneys, starving them of oxygen, and it actually induces a state of metabolic acidosis.
Oh, wow.
So the SMART trial was designed to confront this exact blind spot. It compared traditional normal saline against balanced crystalloids.
Balanced meaning what?
Fluids like lactated ringers, which are specifically engineered with buffers to closely mimic the actual electrolyte balance of human blood.
And the results of the SMART trial are actively changing how hospitals operate today, right?
Absolutely. The evidence clearly shows that using balanced fluids instead of normal saline leads to significantly fewer kidney injuries, less need for dialysis, and lower overall mortality in critically ill patients.
That's huge.
We are watching a real-time paradigm shift as modern medicine finally questions the normal saline we've relied on for over a century.
It really emphasizes that no medical intervention, no matter how ubiquitous or seemingly simple, should ever be exempt from rigorous questioning. So let's synthesize everything we've covered today. We have dismantled the plumbing analogy. We've seen that IV fluids are absolutely not just water.
Not at all.
They are highly calculated chemical tools governed by the strict physical laws of tonicity. We explored the D-phi-W paradox, where an isotonic label disguises a hypotonic effect.
Yep.
We talked about the life-saving physics of intentionally shrinking brain cells or swelling dehydrated tissues. And we unpacked the historical tragedies and modern trials, from the 50-year holiday cigar pediatric error to the ongoing movement away from normal saline.
Right.
Which all proves medical science is always, sometimes painfully, evolving.
The main takeaway for you as a listener is that the next time you are in a hospital or you see that clear plastic bag dripping on a medical drama, you're going to look at it with completely new eyes.
Definitely.
It isn't just hydration. It represents a microscopic, calculated manipulation of the physical laws of water inside the human body. Every single drop interacting with millions of cells, governed by equations that took centuries to map out.
I love that. And, I want to leave you with one final thought to mull over. Building on these rules of water movement.
Okay.
We have spent this entire discussion exploring how tonicity and hydrostatic pressure force water to move in a gravity-bound human body.
Right.
But what happens when we leave the planet?
Oh, wow.
Right. In the microgravity of space travel, astronauts lose the normal hydrostatic pressure that pulls blood into their legs. Their bodily fluids naturally shift upward into their chest and head, which is why astronauts often have puffy faces in orbit.
Yeah, I never thought about that.
Yeah, and as we prepare for long-duration missions to Mars, aerospace medicine is having to completely reimagine IV fluid resuscitation.
That is fascinating.
How do you manipulate tonicity, and where does the water decide to go when the fundamental pull of gravity is removed from the equation? It turns out the final frontier medicine might just be relearning how to hydrate a human cell in the stars.